Here is an interesting thought experiment called Mary's Room in Medicine. Imagine Mary, a brilliant cancer specialist. She has spent decades studying cancer, mastering every theoretical aspect, biological mechanisms, treatment protocols, and patient outcomes. Yet, Mary has never experienced cancer herself. One day, she is diagnosed with cancer. Now she feels the fear, pain, and uncertainty her patients have long described. This thought experiment invokes three important philosophical questions which are below. Question number 1. Can theoretical knowledge ever fully encompass the subjective and emotional realities of lived experience? Or is there an inherent gap that only personal experience can bridge? Despite her expertise in cancer, Mary's understanding is limited to objective facts, molecular biology, treatment protocols, and statistical outcomes. However, when she experiences cancer herself, she encounters an entirely different dimension: the anxiety, vulnerability, and hope that accompany illness. This suggests that lived experience provides an irreplaceable layer of insight that theoretical knowledge cannot replicate. While science excels in explaining the what and how, lived experience often reveals the why patients fear, hope, or struggle in ways that no amount of research can fully explain. Question number 2. Does experiencing illness firsthand fundamentally alter a doctor's ability to provide care, or does it risk biasing their clinical objectivity with personal emotions? Mary's diagnosis also raises a philosophical tension. Does her personal experience enhance her ability to empathize and provide care, or does it risk compromising her objectivity? On one hand, living through cancer may deepen her compassion, making her more attuned to her patients' emotional and psychological needs. She might better understand the weight of treatment decisions and the emotional impact of a diagnosis. On the other hand, personal experience can introduce bias. Her own suffering may influence how she interprets her patients' choices, potentially prioritizing emotions over evidence-based care. This tension highlights the need for balance between empathy and clinical detachment in medical practice. Question number 3. If true understanding requires both theoretical knowledge and lived experience, how should medical education balance these dimensions to cultivate compassionate yet effective practitioners? Mary's story suggests that while medical training excels in imparting technical skills, it often neglects the emotional and experiential dimensions of care. Incorporating patient narratives, immersive simulations, or even encouraging reflective practices could help doctors develop a deeper sense of empathy without requiring personal illness. While lived experience cannot be artificially replicated, fostering a culture of emotional awareness and patient-centered care can help future practitioners like Mary merge objective expertise with subjective understanding. In doing so, the medical profession can advance not only in treating diseases, but also in truly healing individuals. If you like this content, please subscribe and follow for more.